All right. So I apologize, I didn't give you a ton of time to preview the cases, but that's okay. I don't mind if you can at least just sort of describe what you see and we can work through them together. No pressure. As Perry mentioned, you may have seen some thematic bent here, which sort of migrates as we progress through the slides. But we may or may not get through all of them. If we don't get through all of them, I'm happy to just give you guys the diagnoses, and you can ask me questions as needed. All right, so without further ado, I also didn't give you histories because sometimes it's obvious where we're located and sometimes it's not, but we can talk through the places that these things might occur as we go through them. So this is a lesion that I can just tell you right now may occur in soft tissue and may occur in bone. So that being said, does anybody want to give a gander at what they started to see?
Yeah, I can give it a shot.
Thanks, Heather.
So yeah, we've got 3 core biopsies. In terms of cellularity, I think it's like a mixture of like hypercellular, hypocellular areas. Um, yeah, like here's a little more hypercellular. It's very pink, but not like hyalinized pink. So that's one thing. And there are cells. They look like they're like forming a trabecular pattern. In terms of like, striking features of malignancy, like I guess like I don't see like a whole lot of atypia or like weird mitosis or necrosis, so maybe something a little more benign. Oh yeah, I guess Jasmine's saying, have you told me it was breast? Maybe this could be lobular. That is like, yeah, that's one thing.
They're very epithelioid, yeah.
Yes, they are very
And
epithelial and they're linearly kind of oriented. Go ahead.
Very epithelioid, and then there's like areas of like spaces like almost like I think like what they call blister cells, so they're like single nuclear or single red blood cells within these lumens. So I'm wondering if this is like a hemangioendothelioma.
Okay, awesome. So tell us what stains you might want to order and what a hemangioendothelioma is kind of conceptually.
Like vascular markers, I think like Fly1 maybe or C34 or I don't know. Do you ever use GLUT1 in these examples? Maybe it's not very helpful, but
why? Okay, all right, we can talk about all those, sure.
yeah. And then when we're thinking about lobular, I guess like you could just throw a keratin marker. That would be not helpful.
Okay, no, thank you. So what, all right, so then we'll get into the stains and then we'll get into the biologic behavior. So yeah, so the pattern of cords of cells with an epithelioid morphology and not overt malignant, right? Not tons of mitoses, like really no significant pleomorphism. These nuclei are relatively monotonous, but they're epithelioid, they are corded, they're in this kind of variably collagenous to arguably mixoid background. And I think the important diagnostic feature, one of them is hidden right behind this fold, are these intracytoplasmic vacuoles or lumina, some of which may or may not contain red blood cells. And so anytime you see a lesion that is trying to form some kind of structure, you either have to think, okay, is this structure that this is trying to form, is this a duct? Is this a lumen? Is this a vessel? Right? So things that form these little signet ring or duct-like structures also start to think about pseudo sort of endothelial spaces, because these cells in fact are trying to form lumina within their cytoplasm, and sometimes they even contain some kind of material or some kind of red blood cell. Exactly. And so if you put a keratin on this, would you expect it to be positive?
No, but I think it can be expressed in half these cases, so it's like
yeah, right, it can't. So keratin can be positive and can be a distractor, right, in mesenchymal neoplasms, especially those that have an epithelioid morphology. And as you may or may not have guessed based on the subsequent slides, we're going to be seeing a lot of tumors with an epithelioid morphology, many of which characteristically or, somewhat can express keratins. So don't ever let that fool you into ignoring the fact that this could be of mesenchymal origin. Exactly. And so then when you do your vascular markers, like you said, what are the cytoplasmic vascular markers? Somebody can say it or type it in the chat.
These, I think, Fly1 and ERG, maybe.
Okay, those are the nuclear
Those are
ones.
nuclear markers.
Yep, so Fly1 and ERG are the nuclear markers of vascular
Like
differentiation.
CD34.
31,
Yeah,
34.
31 and 34.
34, exactly. So, yeah, so I generally, thanks. I put a broad panel generally on these because not all vascular neoplasms necessarily express all vascular markers. So it's nice to have a kind of a quorum. And so, so those plus keratin would be diagnostic in the context of morphology. So hemangioendotheliomas in general, are they benign, malignant, or something else?
Like in between?
They're in between, right? So there are these tumors of indeterminate or uncertain malignant potential. And so they do not necessarily have a high risk of metastasizing, but they can. Specifically, hemangioendotheliomas of the epithelioid variant can be, there's some nice blister cells, can be multifocal. It is uncertain whether that multifocality in the body means that they are metastatic or multiple primaries. They can arise in visceral organs, they can arise in bone, they can arise in soft tissue. So they're very, kind of, I don't want to say promiscuous, but they really kind of are. And so does anybody recall what the genetic rearrangement is in these in case there's ever a diagnostic dilemma? One can perform this test.
Like the CAMTA1 WWTR, something to that effect.
Exactly. WWTR, Cam, thank you. Exactly. So yeah, so that all things considered, generally a diagnosis can be rendered. And these patients, will be treated, quite carefully in terms of, local recurrence, quote unquote metastasis or recurrence in a different location. Kids, adults, often you see these in sort of young women, but you can really see them across the spectrum. Cool. What else? Anything else on this case?
Maybe a dumb question, but like, how do the cells get, like, how do the blister cells get red blood cells inside of them? I've never quite figured out, like, how does the red blood cell?
I'm assuming they probably express some kind of recruitment markers that are common to vessels. And so somehow the red blood cells that are maybe extravasated from normal vessels can recruit themselves in there. That's my guess, is probably some kind of cytokine.
Okay, I've just always wondered.
Yeah, no, that's my best guess. It's my best
guess. It's reasonable.
All right, and then the next case. So, obviously now we are in a cutaneous or a subcutaneous type of site. And so what's different about this case than the prior?
There is some like vascular, they are trying to find to form vessels or vascular channels. Epithelioid, I believe. Yeah, it's very similar. But the tumor cells are trying to find channels, like vascular channels, more than the previous case. So we have kind of, let's say, vessels, yes, or canalite channels. Yeah.
Okay. What else? So these cells are also epithelioid. However, they are truly forming or trying to form vascular channels where the channel is surrounded by multiple cells, right? Rather than there just being an intracytoplasmic vacuole. Okay.
Yeah, multiple.
Cool. What else?
Multiple layers. Like the cells are monomorphic, like they look alike.
What's striking about them, though?
Very prominent nucleoli.
Yeah.
And very like abundant cytoplasm, like epithelioid appearance. And maybe we have, do we have here any intracytoplasmic vacuoles again?
I wasn't able to see very many, although I do see these kind of eccentrically located little pink areas.
So first of all, I'm not able to know if it's like, it's epithelioid. Is it malignant or like, is it epithelioid? It's different than the previous slide, which is what we call epithelioid hemangioendothelioma.
Right.
So this one, is this epithelioid hemangioma or carcinoma, sarcoma? Like I'm not sure about the borders, like if it's infiltrative or well circumscribed. So from here, I feel like we have here focal, maybe infiltration.
Yep.
Yeah, so that would go more with sarcoma.
Yeah.
Yeah, that would go more with sarcoma, I believe. So there is one mitosis here.
Yeah.
I'm not sure if we have any kind of necrosis. Yes, here we have kind of apoptotic bodies.
Right.
Yes, and
we at least have some
figures.
central kind of degenerative change, whether that's true necrosis or just kind of intralesional hemorrhage. I don't know, but yeah.
Yes. So the majority of the tumor is kind of solid sheets. Yeah, and we have like irregular vascular channels. We have focal infiltrative patterns. The cells are plump, polygonal. Cytoplasm is eosinophilic.
Yeah.
The nuclear atypia is, I could say, moderate, but it's easy to recognize mitotic figures. So I number one in my differential would be epithelioid angiosarcoma.
Yeah.
Yeah.
Yeah. No, great. Go ahead.
Yeah, there is. Yeah.
Yeah, so that highlights a great point. So, an epithelioid neoplasm that in this case is vasoformative, right? You see many areas here where there's trying to be vessels with at least some, clusters of red blood cells in the lumen. So that is the crazy thing is that your differential exactly is between an epithelioid angiosarcoma and an epithelioid hemangioma, because hemangioendotheliomas really should not be vasoformative. So once you have true vasoformation, you are now dealing with something either completely benign or completely malignant in most cases. Okay, and so that's kind of my gentle rule of thumb for these. And so when it's this large, when you see retinal-mitoses, when you see this many prominent nucleoli, when you see peripheral infiltration, I mean, I think you can favor, like you said, an angiosarcoma. One thing that we have used when it is challenging or a small biopsy to differentiate between a sarcoma and a benign, so an angiosarcoma and an angioma, there's a nice weird mitosis, is actually the presence of a pericyte layer surrounding the vessels. And so I unfortunately don't have a stain here to show you that, but I can kind of perhaps gesture as to how that might be. So do I have the...
So we do actin, you mean?
What?
Do we do smooth muscle actin?
Exactly. And so if you ever have a small biopsy where you have a vasoformative, what you think is a vascular lesion, you've proved it's vascular with your 4 markers up there. And so the other marker you might want to add on, as Riham said, is an SMA. And an SMA in a hemangioma would generally show you a positive pericyte layer around these vascular spaces, whereas it generally would not in an angiosarcoma. And so, other than, mitoses, necrosis, cytologic atypia, that can also be an additional factor that we can come into play for these. Yeah, exactly. So, the other thing I wanted to point out is if you are ever uncertain about the vascular nature of something, especially if it does not form vessels, really always look for hemosiderin. And I don't have this case right now in this because it's an active case currently, but past week, we had a lesion in the femur of a kid that was completely spindled. And one of the clues to its vascular nature was just the fact that there was a ton of hemosiderin, just a ton. And so that's evidence that there was some red blood cell recruitment. Those red blood cells may have lysed, and now they're just being present in the form of hemosiderin, right? So even if you don't see active red cells, if you see a lot of hemosiderin, that could potentially clue you in to the vascular nature when it is non-vasoformative. So those are the things I wanted to bring up on this slide. Yeah, now that we're scrolling around, we're seeing quite a few mitoses, which I think is helping us, again, confirm the diagnosis of angiosarcoma. These can be in the deep soft tissues. These can be in visceral organs. We've had these arise in the parotid before. This case looks like it's sort of in the subcutis. But generally, these epithelioid angiosarcomas arise in the deep peripheral sites or visceral organs. No really known specific genetics here. Any other comments? Okay. I wanted to show you these next two more as a clinical difference. And so, as you can see, in this case, is the lesion quite deep, or is it actually much more superficial?
Superficial.
Yeah, much more.
More superficial.
Yeah, right. So we're like right under the skin as opposed to in the deep subcutaneous. And so, I think you can all gather where we're going here, but there are these very cleft-like pointy spaces, right? Lined by these cells with enlarged nuclei that are hyperchromatic and angulated. And in some areas there are some red cells, but just this cleft-like, slit-like spaces is indicative of some kind of vasoformation. So I won't make you go through the differential again, because I think you can get at that I'm getting at an angiosarcoma. But just like this case, and this case not only has those cleft-like spaces, it also has very solid areas. And so what is the etiology of these that occur in the skin? And it may depend on where that skin is. So anybody have a thought?
As in like
Radiation?
history, like radiation or lymphedema or like Stewart-Trees-Reeves syndrome or whatever that's called.
Like breast treatment, after breast treatment, angiosarcoma or something.
Pardon?
After radiation. Maybe after radiation of breast cancer.
Yep. So after radiation of breast cancer, you can get cutaneous angiosarcomas in areas of lymphedema. Exactly. Generally, after breast cancer, you can get angiosarcomas, even if they haven't been in irradiated areas, they can still be in areas of lymphedema. So that's one. What's the other? Or that's two. What's the third?
Retriform, like it's kind of retriform.
No, I'm saying like, what's the third? You're right about the morphology. I'm saying what's the third etiologic agent for cutaneous angiosarcomas?
Oh,
not like Kaposi sarcoma, right?
From hemangioendotheliomas.
There's generally not a transformation process. No. I'm a head and neck pathologist as well, so let's take that into consideration.
Like Kaposi?
Viral? Well, yeah, I mean.
Okay, that's a totally different type of sarcoma. I'm talking about cutaneous. All right, how about sun exposure? All right, so scalp. So cutaneous angiosarcomas in the scalps generally of kind of old, I don't mean to be rude, but old dudes, like old guys who are out in the world farming, or people who get skin cancers, SCCs, BCCs. These older, generally male people can also get cutaneous angiosarcomas of the scalp in secondary to sun exposure. All right, and so not only in the they look very similar, right? They can start as these as was mentioned, these sort of retiform vascular spaces where the endothelial cells exhibit just a hint of overlapping and hyperchromasia and enlargement. So right here, that's sometimes all you're going to get. That's angiosarcoma, but it's highly infiltrative. right? If you put a CD31 on here, which I think these people did, you can see that it is extraordinarily infiltrative. And this process of trying to resect these in the scalps, especially of these people, can be quite disfiguring because they track so far, and you can even see small foci of tumor, percolating through what might otherwise be a, generally normal appearing area on low power, right? So I guess that was nuclear. So I think that must have been, that must have been like an ERG or a fly one. And this must be the cytoplasmic. Yeah, exactly. And so, so what's my point here? Yes, my point is radiation, lymphedema, and sun exposure, starting from just this highly infiltrative small vascular process to a much more aggressive, epithelioid. And you can get a range of any of these morphologies and patterns in the same patient. Okay. Were these lymphangiosarcomas? Oh, the ones that were lymph related? Maybe, although I don't think that term is used anymore.
Yeah, I was hung up on the epinym. You can disregard.
Okay, yeah, because
according to Google, it's angiosarc.
Yeah.
Specifically.
Yeah, because I think once you start saying lymphangio, you almost imply that there's lymphatic differentiation. And in some vascular lesions, there are, like in this, in some vascular lesions, you can actually have D240 expression, which implies some kind of lymphatic differentiation as well. But yeah, mostly we don't tag the two exactly. Okay, did that all make sense? Is there other questions? Okay. Does anybody remember the name of the thing in the breast that's like the early form of these vascular lesions that could transform to angiosarc? I like the eponym. I think it's this atypical post-radiation vascular proliferation. And so those of you who see skin or see breast or see soft tissue biopsies, remember that this is the one area where you can actually get progression from these atypical post-radiation vascular proliferations, potentially to angiosarcomas in these radiated areas. Okay. Next, also in the skin. Whoops. I know I did not give you guys the IHCs here on your preview cases, but I have a few, as you can tell here. So does anybody want to describe this guy?
I can describe this one. So it's under the epithelium here, and it's an ill-defined, very basophilic lesion with really pleomorphic. There's some. I'm sorry, it's a little bit blurry on my computer screen here.
I'll stop.
Oh, there we go. Okay. And on high power, the cells are very large and ugly appearing. There are the nuclei are vesicular, and there are some cells that are really large. So there's lots of pleomorphism. And I saw in my view lots of mitotic figures that looked atypical.
Yep. Yeah, there's 3 right there.
Right. And I think that I was wondering to myself whether the lesion was vasoformative because I saw some slit-like spaces. There are vessels that might also be entrapped. So that's a question. Is it vasoformative or is it entrapped vessels? Okay. So the cells are epithelioid, if I didn't mention that, and sheet-like. And I think at the periphery, I don't know if I mentioned that I thought that it was sort of infiltrative because it was sort of ill-defined. And
there's a lot of nests out here. There's some percolating into the fat.
And there's an area of necrosis on the periphery that we haven't seen here, but I think I noticed myself.
Yeah, I was stopping on this one area because I thought it had such nice cells, but now I've lost it. We'll find some more again. Did anybody notice what few cells I was resting on? Here's a few.
Pretty few giant cells.
The little rhabdoid.
Yeah, they have a little bit of a rhabdoid appearance, at least here with this sort of a very vaguely pale, eccentric eosinophilic substance in some. Here. There.
Yeah.
There. All right, so you have something epithelioid, sheet-like, that appears quite malignant with lots of mitoses, and here's your necrosis, with an occasional rhabdoid appearance, not necessarily overtly vasoformative, but certainly you'd want to consider, a solid epithelioid angiosarcoma. But I'll just tell you that the vascular markers are negative in this case. So with a malignant epithelioid and rhabdoid type of tumor, in this case, it was in the chest wall. What do you want to do? What do you want to tell me what stains you want, and I'll tell you.
We want to
INI1.
do vascular and INI1 and BRG.
Okay, so vascular markers are negative, and INI and BRG. Tell me why you want those.
Thinking
They
like
have loss.
extrarenal rhabdoid,
Mm-hmm.
but I think also epithelioid sarcoma.
Yep.
So
Mm-hmm.
it kind of looks like both of them.
Exactly. So
Mhm.
yeah, so great. So let me just pause there for a second. Yes, I'll tell you, this ended up being an epithelioid sarcoma, but the things you always want to consider with those rhabdoid appearances, are any of the chromatin remodeling complex tumors. So you'd want to do an INI1 and a BRG1, because you can put it into, any number of chromatin remodeling complex malignancies once you have that knowledge, if one of them are lost. Okay, this is INI1 lost. However, don't forget that appearance could also actually be like rhabdomyosarcoma, right? Or something with rhabdoid differentiation. So you'd certainly want to at least attempt like a Desmond, and if the Desmond is positive, a myogenin, just to exclude or confirm any kind of rhabdo or rhabdomyoblastic differentiation. Yep. So I think of the chromatin remodeling complex, and I think of the muscular. But yes, this was INI1 lost. What else do you want to know if it's INI1 lost? What are our options now for INI1 lost tumors? They can be carcinomas, sarcomas. What other information do you want? Are you going to do a keratin?
Maybe like an EMA
Yeah.
Okay, what do you expect?
for this one, positive.
Yeah, yep. So keratin positive mesenchymal quote unquote neoplasms are highly common. Okay, don't forget that. So this tumor is ragingly keratin positive, and devastatingly INI1 negative. All right, so here's your INI1. Then you have to take into consideration, okay, this is a keratin positive INI1 lost lesion. Where is it located? Okay, because this might be a matter of semantics. I don't know, but is this a carcinoma or is this a sarcoma? And so generally the thought is, if this arises in a visceral site like a lung, there are these chromatin remodeling INI BRG lost carcinomas. Okay, but if this arises in a soft tissue site that is not a visceral organ or not epithelial organ related, then it's considered a sarcoma. And this is completely sort of semantics about where it originates. Generally, these are always bad. Like these are just bad tumors. And so, what kind of treatment these patients get may or may not actually, affect them. But generally, if it's in a soft tissue sarcoma type of site, it's a sarcoma epithelioid. If it's in a visceral organ like a lung, it's a carcinoma. And what that means for the patient, I don't know. But I would argue always check your internal control on these stains in which you are looking for loss, okay? Our lab tends to do a very good job with most immunostains, but we've seen cases on the outside that are misdiagnosed because they call the tumor lost, but there's no internal control, okay? And so that's not an accurate stain. And then when you repeat the stain in your own better lab, like you will find that in fact it is not lost. It just was a poorly executed stain. So please, please, please keep that in mind with any stain in which you are looking for, oh, there's a beautiful mitosis. Any stain in which you are looking for loss, just confirm your internal control, okay? Genetics can also, of course, prove this with biallelic INI1 or BRG1 loss. But those are my caveats for this. What else? Extrarenal rhabdoid tumor, I will mention it since you guys did, is essentially morphologically and genetically nearly identical. What's the only sort of real difference that we have in our pockets for which we call one and the other?
Those can stain CD99, right? I don't remember epithelioid sarcoma staining for that.
I don't know, but a lot of things that stain for keratins can also stain for the CD marker. So I also am not entirely sure.
And then S100 too.
Mm.
I think we had one of these while we were on heme, and we were like between those two.
Yes, we were between those two, and the difference is clinical. So the difference is, yep, thanks, Jasmine. So malignant extrarenal rhabdoid tumors are generally, Jasmine, tell us, can you speak? Do you have a microphone or can you type it? No mic. All right, so where do extrarenal rhabdoid tumors generally occur? What age? Sickle cell trait, perhaps, also those without. Kids, so generally younger people, yep, with sort of paraspinal or paraaxial masses. And epithelioid sarcomas tend to be in adults and not necessarily in the paraspinal or paraaxial space, but in any sort of deep soft tissue of the extremities. The proximal type of epithelioid sarcoma, as this is in the proximal, soft tissues, chest wall, trunk, whereas the distal type of epithelioid sarcoma tends to be in the digits, right? So just remember, distal epithelioid sarc, proximal epithelioid sarc, and malignant extrarenal rhabdoid tumor can somewhat differentiate themselves based on site and for extrarenal rhabdoid, age. But really, they're essentially, it's kind of splitting hairs. Does that make sense? Okay. All right, if there are no other questions, I'll start moving on to the next slide. And each case now, we start to progress and see something a little bit different. And it's really these subtle morphologic differences that can really push you into one sort of pattern of thought or another, right? So, cytology, the presence of vasoformation or not, the presence of rhabdoid type cells or not. And in this case, I'm trying to highlight something that is now unique here. Yeah, myxoid, exactly. So we now see an epithelioid neoplasm that for all intents and purposes is very similar to the others, right? But now has this myxoid-like background. And we want to rely on these morphologic clues to help guide our immunoprofile and our differential diagnosis. I can tell you where this is. It's not going to really matter. This actually ended up being an intraosseous tumor that had completely eroded the bone of this was the mandible actually. But these tumors can occur in the bone and they can occur in the soft tissue of the trunk extremities. So just putting that out there, this happened to be a mandibular tumor. All right, so what does this myxoid imply to you, and or how does your differential diagnosis change? Plasmacytoid, definitely.
Something about this made me think of myoepithelioid, carcinoma because of the myxoid.
Okay, because of the myxoid.
And the epithelial cells.
Yeah, so
well, there's really pink epithelioid cells that are in nests and cords.
Yep.
And they have this, pink inclusion, and that's like pushing this plum of the nuclei are eccentric because of it. It's a well circumscribed lesion as well, with we saw that before when no one mentioned it, with a thin kind of pseudo capsule. And kind of vaguely lobulated.
Okay. Awesome. Yep. So
older patient.
Go ahead.
Is this an older patient?
No, this was a young guy, 20s, I think 20s or 30s. Does that change your thought?
Yeah, I mean, I was thinking along the lines of like the proximal type epithelioid sarcoma with a myxoid stroma, like kind of being nodular.
Yeah. Yes, that is completely possible. There are a few differences that are going to help make this differentiate between an epithelioid sarcoma and what Magna mentioned, which was a myoepithelial tumor. And so, yes, these additional immunomarkers are some of them. So whereas epithelioid sarcoma is really keratin and INI1 dependent, you now also have to add on to this case, this certainly should be positive for either a keratin or an EMA, right? So any myoepithelial tumor is going to have to be positive for keratin or EMA, right? One of the two, plus some other evidence of myoepithelial differentiation, whether that be something like an S100 or Fletcher, you read about likes GFAP, or what you expect to see in a salivary gland site, like an SMA, a calponin, a P63 or P40, or for that matter, like a high molecular weight keratin. So any one of those markers in that bucket, if you also have positivity for, you can call this essentially myoepithelial. The myxoid background goes very well with that, which isn't quite as frequently seen in these other types of tumors, but the very, very characteristic for myoepithelial lesions. And so the morphology of these cords of cells with the myxoid background, with, as we were seeing before, some of that very plasmacytoid, or even one might argue, rhabdoid morphology again, should make you at least put this panel of markers on it. And if any one of them is positive, you can now call it a myoepithelial carcinoma or a myoepithelioma. You'll have to determine at that point whether it's benign or malignant. And so does that make sense? That applies for myoepithelial tumor, that algorithm that I put in the chat applies for basically myoepithelial tumors of any site, whether they be salivary gland, bone, soft tissue. The profile in salivary glands, they tend to have more myoid markers like SMA, calponin, P63. In non-salivary sites, they tend to have more like S100. I'm going to actually even add in there like SOX10, GFAP, but it's thought that they're sort of similarly patterned. How do you tell? Can this have INI1 loss? Yeah, some of them do. Okay, so yes, some of them have INI1 loss. So now you're sort of relying on the immunoprofile to differentiate epithelioid sarcoma versus myoepithelioma. And what other gene problem do myoepithelial tumors have? Thank you. EWSR1 rearrangements. Exactly. So we have used the presence of EWSR rearrangement in something with this phenotype to help confirm myoepithelial differentiation. It's not, it's not the players like FLY1, ERG, WT1. It's not the rearranged partners that are in the small round blue cell tumors. It's like others. It's like POOF and I don't know, there's a whole bunch of them. I don't even know because it's not a uniform partner. It's EWSR plus something else, not fly, not ERG, not WT1. Okay. And so then how do you make the distinction? I think this is a good point that Magna brought up, that this is actually quite well circumscribed, at least in these fields. How do you make the distinction between benign and malignant? This is circumscribed, so it's benign. This is necrotic. So
I mean, yeah, the necrosis and I guess like the general pleomorphism, I would be pretty worried. This doesn't look like a benign entity.
Yes, correct. So this is malignant. Myoepithelial lesions, especially those of non-salivary gland, can be circumscribed and still be malignant. And so you see mitosis 1, 2, 3 right here. You see nucleoli. So mitoses, cytologic atypia, 1, 2, nucleoli. So those two things and necrosis, you're done. This is malignant myoepithelioma. Okay, so you can call it malignant myoepithelioma. You can call it myoepithelial carcinoma. Either way, it's essentially the same entity. But yes, you really have to drill down on the details, because you can't just rely on that low power circumscription. Great. Anybody else? Okay, well done, guys. Next case. Seemingly circumscribed, but look, it infiltrates fat. And look, it's trying to be necrotic. All right, so I think we have malignant going for us. But what kind of malignant? Maybe not quite as pleomorphic, or maybe not quite as mitotically active as the prior, but what do you see here in this pattern?
It's almost like vaguely alveolar, or I mean, yeah, maybe cords is a better word.
Cords sort of separated by these very
they're sort of
bright,
these delicate, very pink.
And you might remember the cords of the epithelioid hemangioendothelioma and consider that looked like lobular. Some might also look at this and consider, wow, there's these cells and cords that almost could look like lobular breast cancer. And, we're lucky today to see this on a giant, histologic resection section, but you may be dealing with these diagnoses on biopsy. And I know I try to give you guys biopsies, but sometimes they're just not available, but we do have some coming for the last few cases. So I apologize for that. But this is a gorgeous example of a tumor. Does anybody have any thoughts as to how they're going to approach this? Oh, there's some EO.
This is not like a myofibroblastoma, or I guess I saw one with Dr. Kraus that looked kind of similar to this, at just like basic morphology.
Okay.
Although the necrosis and nastiness doesn't necessarily fit at all.
Right. So tell us how you would work up. So we have a myofibroblastoma. We have an MPNST in the comment. Okay. How would you work those things up?
Riham, did you want to go with your MPNST, or so? I mean,
right.
for like we could do. I mean, like RB would be the classic for myofibroblastoma. Again, like this just sort of reminded me of what we saw with Dr. Kraus, but I don't necessarily think that that's the best choice.
Got it. I mean, that's a good point in as much as there is morphologic overlap between a lot of soft tissue tumors, and myofibroblastomas can have this sort of monotonous cellularity, this linear arrangement. But arguably, maybe the nuclei in a myofibroblastoma are maybe less, I don't know, plump. And yes, you would expect loss of retinoblastoma, which this does not have. So, okay, done. But okay, MPNST will do S100. So yeah, most MPNSTs that are plumper or epithelioid actually retain S100 more frequently than the spindle cell MPNSTs, which generally lose S100. So would you characterize this as more plump or more spindled?
I think this looks a little
relatively plump.
Yeah, this is sort of plumpish. So I'll tell you in this case that S100 is negative. And that should help us because we think plump MPNSTs are more likely S100 positive. All right, so it's plump or epithelioid. It is
No.
Go ahead.
I guess I'm saying liposarc, and you're saying this was S100 negative.
It's S100 negative, but that doesn't.
That doesn't. No, certainly that doesn't.
Liposarc,
doesn't
or what kind of liposarc? A round cell or a D. diff? Yes, you could. I mean, the answer is it could be either, right? So it could be a round cell liposarcoma that has effaced its low-grade myxoid component, in which case you generally have to rely on genetics. There would really be no other way to help you. Same for if this is a round cell variant of a D. diff liposarc, you'll have to rely on MDM2, but you could also look in the background and try to determine if there's any pre-existing well-diff component.
I was, I guess, wondering also about rhabdomyosarc.
Okay.
I don't know if that's like way too much of a stretch, but I guess if we could get a Desmond or something and just like maybe entertain that possibility.
You could certainly get a Desmond, which in this case would be negative. I think, you can always, you can get rhabdos, you can get pleomorphic rhabdos in adults, and you can get embryonal alveolar rhabdos in kids. Exactly. So don't ever not think about rhabdo. I think that's a good thought. All of your thoughts are very good. I like them all. And, we've got S100 negative, we've got Desmond negative, we've got MDM2 and, DDIT fuss, I'm going to say negative. We
don't, sorry. We couldn't get like HMB 45 or
sure, yeah, you want to exclude a melanoma, absolutely,
or like, yeah, I mean, I guess this doesn't look at all like a melanoma parts, but just maybe
absolutely. No, these are all great thoughts, and the problem is you kind of have to do all of them, right? So if you are thinking about a melanoma or a pecoma, you can have clear cell change in pecomas. Absolutely, you'd want to think about your melanocytic markers. In this case, it would be negative. Oh, did I stump you guys? Oh my goodness. No, keep going. Okay, Ryan, MUC4. Why MUC4?
I mean, this is the perfect field for kind of like single filing between these like sclerotic cords, so like a sclerosing epithelioid fibrosarcoma.
You got it. So that's again the very subtle and very focal morphologic finding that's going to maybe clue you in. So these strands of very bright, which we saw earlier in the separating these cells into cords, these sort of hyalinizing sclerotic or collagenous bands are highly characteristic of quote unquote sclerosing epithelioid fibrosarcoma. And so sclerosing epithelioid fibrosarcoma is positive not only for MUC4, but also for
EMA,
yeah.
Yep. So I generally, when I'm evaluating these types of tumors, I generally do both because sometimes EMA is not so great. MUC4 is generally excellent. And really, when you have MUC4 staining in something that you have really proven cannot be anything else, it's very helpful for these types of diagnoses because MUC4 is positive in very few things. What else could you do genetically if you want to confirm that impression?
Like fish, like various fuse Krebs type rearrangements.
Exactly. So I'm just going to type it in there. So the genetics immunoprofile, both of sclerosing epithelioid fibrosarcoma and its similar relative. What's its relative?
LGFM, yeah.
Yep. So low-grade fibromyxoid sarcoma, LGFMS, and sclerosing epithelioid fibrosarcoma have nearly similar genetics and identical EMA MUC4. Basically, that's it. That's all they stain for. So in a tumor that either has that, low-grade spindle cell morphology with myxoid and collagenous zones, or this much more cellular type of morphology with almost lobular-like bands. Think about, oh yeah, there's another area right there that's really nice. Think about this spectrum of tumors. And SCF can arise de novo, as I think it probably does in this case. There is no pre-existing low-grade area, or it can transform from an LGFMS, okay? But the pitfalls in sclerosing epithelioid fibrosarcoma are all of the above, as you mentioned, including and not limited to the fact that these collagenous bands may be perceived as osteoid. And so if you see this pattern in bone, we have done this before. Sadly, we have thought this was osteosarcoma when it is really SEF. Now, one sarcoma type to another sarcoma type, thankfully, is not as big of a deal as recognizing this as a sarcoma and having the patient get treated appropriately. But a pitfall for this is mistaking this as osteoid. And so, anything that is remotely suspicious, just do the EMA and the MUC, and you'll get hopefully the right answer. Does that make sense? Okay. In the last 5 minutes, we're now migrating. Our pattern is now migrating, but I'm going to argue we now have the differential again of something plump with a myxoid background. So I refer you back to our epithelioid with myxoid background myoepithelial tumor case and remind you that this is where we sort of started, and we can now migrate to this other tumor with epithelioid cells in a myxoid background. If you want, would it be helpful for you guys if I just went over these myself and sort of told you what they are and you could look at them on your own, or how do you want to approach it?
We do actually have a sort of surprise open slot on a Friday coming up. I don't know if you would like to continue, and that way we could continue to work through it. So I think, let me just pull up the calendar to be positive, but I was just thinking about it now. I think, is it the 18th? No, sorry, I think it's the 25th. 25th, if I'm not mistaken. I don't know how you'd feel about that, or if you just want to continue, sort of quickly going through them right now.
I will be here. I will be available. If you'd rather have us do it the regular way, I can, like at 8.
Would that be, yeah, if the residents want that, I guess.
I like doing it the regular way.
Okay.
Yeah, I will vote for that.
So we have like 1, 2, 3, 4, 5, 6. Yeah. If we don't take the whole hour, fine, but we can at least, yeah, that's fine. Okay.
I'm saying also, yeah, that way we can do it in a sort of leisurely way and have better discussions and so forth.
Yeah, that sounds great.
All right.